Good morning, everyone, and good evening to all of you across the world. The topic for first of all, I want to thank Dr. Satpathy for inviting me for this presentation. The topic of my presentation is tips, variceal embolization, and retrograde transvenous obliteration in the management of variceal hemorrhage. Recently, I was part of the tips and variceal embolization writing group for the AASLD. And the goal for this conversation, for this presentation today, would be to bring out what are the main guidance statements regarding these procedures as they have become more available. There have been several recent advances, and they're also more popular. We'll also discuss some data behind these recommendations, or maybe the lack of them. We will get to it then. Let's see. These are my disclosures. Okay. I'll start with the purpose and scope of this presentation. I will be discussing interventional radiology-guided endovascular therapies for variceal hemorrhage. This is very specific because I will not be touching upon other indications for endovascular therapies, especially TIPS. I will also not be talking about endoscopic therapies for variceal hemorrhage. I will first go through the anatomy of portosystemic collaterals. We'll go on to discuss the technical details of endovascular treatments, namely TIPS, which is transjugular intrahepatic portosystemic shunt, RTO, which is retrograde transvenous obliteration, and ATO, which is anterograde transvenous obliteration. And then we will discuss the clinical use of endovascular treatments in variceal bleeding. Now, the ultimate goal of this presentation would be to facilitate multidisciplinary discussions between hepatologists, gastroenterologists, interventional radiologists, and surgeons in selection of endovascular treatments for variceal hemorrhage. Now, we'll go on to start with the anatomy, and I'll talk about the portosystemic collaterals in portal hypertension. Right? So there are common portosystemic collaterals that we encounter, namely esophageal varices and gastric varices. Collaterals that are present in the gastrointestinal tract are commonly referred to as varices, whereas those outside the gastrointestinal tract are called as collaterals. This is getting into semantics, but that is how we decided it would be. Collaterals can also be present in other parts of the gastrointestinal tract, such as duodenal varices and rectal varices. Now, they can also be present in surgically created sites, such as stomas, and they're also called stomal varices. We'll go on to TIPS, right, which is transjugular intrahepatic portosystemic shunt. The goal of TIPS is to decompress the portal circulation into the systemic circulation with the aim of reducing the portosystemic pressure gradient and decreasing portal hypertensive complications. Now, the portal vein is first accessed, and an intraparenchymal tract is created inside the liver. In this intraparenchymal tract, a polytetrafluoroethylene-coated expandable stent is used to line this tract to the ostium of the hepatic vein. Okay, now it has several effects. It shunts the blood away from the liver, which leads to 50 to 100% increase in right atrial pressure. And because of the ionotropic effect on the left ventricle, there is 10 to 15% increase in cardiac output. Sorry. Unsurprisingly, it can also lead to increase in right ventricular pressure, pulmonary arterial pressure, and thus the pulmonary capillary wedge pressure. And these are important as we consider in which patients we put TIPS. It shunts the blood away from the liver, so it can reduce liver function theoretically. It can worsen encephalopathy, our greatest fear with TIPS, and it can decrease renin and angiotensin levels, and it can lead to improvement in renal function. Now, the goal of TIPS is to balance the gains that we get in terms of ascites, nutrition, renal function, and control and prevention of future variceal bleeding with its effects such as worsening of hepatic encephalopathy or worsening of liver function. In this regard, the standard of care should be considered to be the PTFE covered expandable stent, because there is a lower risk of stenosis in them, lower risk of thrombosis within them, and they're associated with better outcomes, portal hypertensive outcomes. And when the indication of TIPS is variceal hemorrhage, which is either treatment of acute variceal hemorrhage or prevention of recurrence, the TIPS should be progressively dilated, starting at 8 millimeter diameter to the minimum diameter, which is required to achieve a porosystemic pressure gradient below 12 millimeter of mercury. And this is a new advancement, let's say, in the last 2 decades. And it has been shown that the 8 millimeter diameter stent may be enough to prevent recurrence of bleeding and prevent complications like hepatic encephalopathy. And now the stents that we have are a variable diameter and can be increased to reach the optimal porosystemic pressure gradient as compared to previous stents that had fixed diameter. In patients in whom porosystemic gradient does not decrease below 12 millimeter of mercury, despite maximum dilation, non-selective beta blockers should be added to decrease portal pressure. Now, this recommendation comes because people with TIPS and a porosystemic pressure gradient greater than 12 millimeter of mercury have 8.5 times the risk of developing portal hypertensive complications than those with a lower porosystemic pressure gradient. Also, I think there is a study that follows patients with TIPS for at least 2 years, and it shows that patients with the higher porosystemic pressure gradient have had greater complications, like there were 35% risk of ascites and variceal bleeding as compared to those who had a gradient below 12 millimeter of mercury, where only 5% of patients had these complications. Now, the porosystemic, we talk about HVPG, and which is hepatic venous pressure gradient, which is a surrogate for portal pressure, which is the difference between the, the inflated balloon, which is the wedged hepatic pressure minus the free hepatic pressure. Whereas the porosystemic pressure gradient is an actual measurement of portal pressure while you're putting in the TIPS. And to calculate it, it is recommended that the intra-abdominal IVC pressure be subtracted from the pressure, the portal pressure. Very often in IR reports, you may see a right atrial pressure being used, but this can overestimate the porosystemic pressure gradient. And the way I suggested before has been shown to best link with outcomes rather than the one with right atrial pressure. Now, bland portal vein thrombosis does not preclude the creation of a TIPS, and referral to an experienced center should be considered. The canalization of portal vein thrombosis may also make it easier for transplant procedures, and it can be done and it should be considered on a case-by-case basis with IR consensus. In patients with large spontaneous porosystemic collaterals, collateral embolization at the time of TIPS placement may be considered, since it may decrease the risk of hepatic encephalopathy. When we discuss the transvenous obliterations, we'll touch upon it further, but the complex of the nidus of varices, especially gastric varices, may have their own afferent and efferent supply, which and the pressure inside those may not decrease with TIPS. So collateral embolization at the time of TIPS placement may be considered. Now, the contraindications of TIPS, we learned about what are the effects of TIPS on the heart, and the absolute contraindications really are congestive heart failure, severe pulmonary hypertension, severe uncontrolled hepatic encephalopathy, and uncontrolled sepsis. In practice, In patients who we consider TIPS in, we do get an echo, even though it is an emergent setting. We do get an echo before we proceed with TIPS. And severe uncontrolled hepatic encephalopathy is not the patient who presents with a variceal episode and is confused or obtunded because of that episode, but it is that patient who was getting admitted to the hospital every few weeks for hepatic encephalopathy before the bleeding event. There are several relative contraindications, and over time, this has we would often get pushback from IR, who would quote that this patient has MELD greater than 15, so we cannot do TIPS in this patient. But that has decreased over time, and it is because of these multidisciplinary consensus brought out by various societies and more awareness of TIPS as a treatment for patients with high-risk bleeding. So there is no specific MELD threshold for TIPS, and most TIPS studies used CTP score, and patients with greater than 13 were excluded, and these patients will have high MELD. None of these studies had patients greater than 75 years of age. And other relative contraindications would be untreated biliary obstruction, severe coagulopathy, and there may be technical difficulties if there are tumors in the liver or the patient has polycystic liver disease. Now, the main complications of TIPS are related to hepatic encephalopathy, the deterioration of liver function, and cardiac volume overload. Now, the biggest complication of TIPS to consider would be hepatic encephalopathy, and 30 to 50% patients after TIPS would have at least one episode of hepatic encephalopathy, and 8% of these would be actually severe. The risk factors for encephalopathy are not very different from other indications. If the patient has had previous encephalopathy, if they're older, if there's advanced liver dysfunction, kidney dysfunction, hyponatremia, sarcopenia, and if the post-TIPS poor systemic pressure gradient is very low. And these are the risk factors for encephalopathy, and it's the commonest complication of TIPS. Now, deterioration of liver function, the TIPS will shunt away blood from the liver. It is difficult to say how much of the dysfunction is because of the TIPS and how much is because of progression of liver disease, especially if the TIPS has been put in a very sick patient. But objectively, when studies have looked at this, there has been no increase in liver function-related death, but there may be a small increase in bilirubin and INR. Cardiac volume overload is a big one. 20% of patients will have cardiac decompensation after a TIPS, but it is believed that these patients had a cirrhotic cardiomyopathy before the placement of TIPS. And here, I can't stress enough how important it is to get that echo, because oftentimes that is undiagnosed. There is 5% related mortality, and 4% patients will develop new pulmonary hypertension. Procedure-related complications related to the TIPS, such as a hemorrhage or a capsular puncture or infarction or sepsis, are actually very low and seen in less than 1% of the patient. And overall, it can be a safe procedure in good hands. Now, in patients who are undergoing elective TIPS for prevention of variceal hemorrhage, you can give rifaximin 550 milligrams. The guidance statements would say started within 14 days of TIPS placement, but this is acute variceal hemorrhage. Nobody could have predicted it 14 days earlier, but we'll get to that. And it can be maintained for 6 months and may reduce the risk of post-TIPS hepatic encephalopathy, and can be considered. This can be considered when it's feasible. So there is a randomized control trial. It's double-blind. It is for patients who get a TIPS for refractory ascites. And they were randomized to get rifaximin or no rifaximin started within 14 days of TIPS placement. Now, these patients who were on rifaximin had lower incidence of incident hepatic encephalopathy after the TIPS. And this guidance statement is extrapolated from that. in the study, most patients, actually 80% of them had alcohol-related cirrhosis or hepatitis-related bleeding. And it is difficult to say if this can be extrapolated to patients, first of all, with variceal hemorrhage, and secondly, to NAFLD patients or patients with other etiologies. In clinical practice, when we see a person with alcohol-related hepatitis, the variceal bleeding is such a dramatic event that most of them do stop drinking in the ensuing few weeks to months, at least. But I find NAFLD very related variceal bleeding very distressing. I feel like I can't fix anything, and it remains to be seen where rifaximin in that setting will be helpful. In patients with refractory encephalopathy, despite post-TIPS optimal medical therapy, which is a combination of lactulose and rifaximin, if the patient keeps getting admitted to the hospital with encephalopathy, endovascular reduction of TIPS diameter can be attempted. And again, if your pressure comes up, the porosystemic pressure gradient, that is, if it comes up more than 12 millimeter of mercury, you should put the patient on beta blockers, and beta blockers can lead to further reduction of portal pressure by 10 to 15%. Now, follow-up of TIPS. TIPS dysfunction is defined as this loss of this porosystemic pressure gradient, this less than 12 millimeter mercury that was created. There's this loss of that, and there's rise in porosystemic pressure gradient. And that can happen because of stenosis and thrombosis. And the incidence of that is actually low. At 1 year, it may be about 90%, and at 3 years, maybe around 75%. However, a proactive follow-up of this is recommended because the consequences are dire, right? You can have recurrence of bleeding, or in a person who had ascites, concomitant ascites, you can have worsening of ascites. So a proactive follow-up is recommended. And Doppler ultrasound can be done at 1 to 4 weeks, at 3 months, at 6 months, and every 6 months thereafter. And typically for the latter, I combine it with HCC screening. Now, we can look at the velocity in the portal vein and the direction of the flow to determine whether there is TIPS dysfunction. A mean maximal flow velocity at the portal vein, less than 28 centimeter per second when the flow is hepatofugal, or less than 39 when the flow is hepatopetal, should trigger venography and pressure measurements to confirm this TIPS dysfunction. But you should also suspect TIPS dysfunction when it's obvious, when you see worsening of ascites. Typically, that is how most people will present. TIPS dysfunction should be considered proactively. We move on to retrograde transvenous obliteration, or RTO. Now, retrograde transvenous obliteration and anterograde transvenous obliteration, that I'll refer to as ATO, they can be performed as adjuncts to TIP, or they can be performed alone, and they're typically performed for non-esophageal varices, typically gastric varices, as they are shown in this diagram, the GOV2s, sometimes IGVs. And for retrograde transvenous obliteration, they are accessed by a systemic vein. And here, this is a shunt. This is a gastrorenal shunt. Gastrocaval shunts are also possible. And in this procedure, this diagram particularly shows a balloon retrograde transvenous obliteration, because you can see that there is a balloon that is inflated in this gastrorenal shunt, and a sclerosant is injected in the system to obliterate the gastric varices. Now, when all this variceal system is obliterated, this will redirect flow back into the liver for the improvement of hepatic function. This would increase the porosystemic pressure gradient. And in theory, this can cause progression of portal hypertensive complications. In fact, the development of collaterals after RTOs is common, and up to 60% of patients can develop collaterals, especially varices, after RTOs. There also can be worsening of ascites or hydrothorax in up to 10% of the patients. And, as it redirects the flow into the liver, in theory, the liver function actually improves. We'll talk a little more about that. Now, RTOs have high success rate. There is resolution of gastrofungal variceal hemorrhage in 96 to 100% of the patients. And when done properly, the recurrence rate is very low, less than 3% in 3 to 10 years of follow-up. It should be considered as an alternative treatment to TIPS for bleeding gastric or ectopic varices with favorable anatomy. That is an accessible, the most important being the accessible and occludable gastrorenal or gastrocaval shunt. And as we discussed its effects, the close surveillance of complications of portal hypertension after RTO is needed. And, the patient might also need additional treatments such as TIPS, beta blockers, and endoscopic treatment of varices may also be necessary if you see varices on surveillance, close surveillance that would be done after RTOs. Now, I want to talk a little bit about the types of RTOs, and all RTOs are not the same. Now, this picture is the same as the last one, and it shows this balloon retrograde transvenous obliteration. And this is the first type of RTO procedure that was made. And in this procedure, you can see that the balloon is inflated in the gastrorenal shunt here, right? And after the balloon is inflated, there are sclerosants that are injected into the system. And the balloon is important because you don't want this sclerosant to flow back because it can cause catastrophic complications sometimes, such as the stenosis, such as the thrombosis of the renal vein or the portal vein. Now, the sclerosants are, I think, sodium tetradecyl sulfate is a common one that is used in the US, like ethanolamine oleate is the one that I see in papers from Japan or India. And when this BRTO is done, this balloon has to, with these kind of agents, this balloon has to remain inflated for 36 to 48 hours, and the patient goes to the ICU while all the system is getting sclerosed with this. Now, that sounds long. You require that time, all right, because this is a variceal hemorrhage. Mostly there is that time to do that. However, this is very complex and has certain risks, right, as discussed. So this is a modification of the procedure. This is called PARTO. If you ever read that, it's plug-assisted retrograde transvenous obliteration. Now, instead of a balloon, there is this Amplatzer plug, which is there used in this system. Now, also, the sclerosing agent can be like gel foam slurry, which is commonly used in this PARTO technique. Now, when you use the slurry, the process is relatively shorter, and you don't need to go to the ICU and stay there with an inflated balloon. And so the procedure time gets faster. But if you see, the plug is actually quite big, and it can be difficult to deploy technically, especially if you have all these angles. In the light blue color, you can see from the IVC all these great angles that you have to negotiate with this plug. And if you have a really large shunt, you actually may not have a plug that big to occlude that site. Now, there's another modification of this procedure in which you can use coils, right? So instead of the balloon or the plug, we're using coils here, and you don't have a size problem here. They may be easier to negotiate. You can put 2 or 3 coils. Again, use gel foam slurry and decrease the duration of the procedure. So CARTO and PARTO have lower complication profiles compared to those of traditional BRTO or modified BRTO, and may be the preferred methods at experienced institutions. So the contraindications would be severe sepsis, if there's splenic or portal vein thrombosis, if there's difficult to control ascites, and you'd be increasing portal flow and potentially worsening portal hypertensive complications. Anatomical factors may play a role. And complications, I briefly touched upon this. Now, if you have escape of this sclerosing agent, you can have portal and renal vein thrombosis, disseminated intravascular coagulation, even anaphylactic shock or stroke. And we talked about portal hypertensive complications. This is anterograde transvenous obliteration. You can see that in this, if you look at the diagram, there is percutaneous access to this left gastric vein, which is feeding these nidus of varices, these GOV2s. Now, you can see that there is no systemic access, such as this gastrorenal shunt in this case. Now, it can be a technically more difficult procedure, and literature shows that the complete obliteration of varices and cessation of flow is in like a wide range from 44 to 100% of patients, depending, I think, on technique, expertise, follow-up. I want to warn you that these RTO and ATO recommendations are based on large case series mostly, and the level of evidence to support this, if I look at TIPS related evidence is much lower. But the success rate seems to be higher, and a randomized control trial seems to be difficult, and we'll get to why. Now, before that, percutaneous transhepatic, transplenic, or trans-TIPS ATO should be considered as a therapeutic option in gastric, esophageal, and ectopic variceal hemorrhage with large afferent vein or shunt with high flow varices. So basically, you can put a TIPS, but since this complex, as an example, this complex here, if it has very high flow, the varices may continue to be fed even if you put a TIPS. So this should be considered as an adjunct to TIPS or alone by itself. Now, ATO with complete eradication of entire variceal complex is advisable because a partial eradication of this complex is associated with high risk of bleeding. So you have to go back and look whether the complex is entirely obliterated. Now, a contrast as a follow-up to look for this, a contrast-enhanced abdominal CT or endoscopic ultrasound should be performed within 2 to 3 days after RTO or ATO to confirm complete obliteration of varices. In our practice, we typically do a EUS to assist with this. And we should perform a follow-up endoscopy in 1 to 2 months to evaluate the development and worsening of varices. And if you don't see any varices, the future surveillance should be performed according to existing guideline. And if you see varices, they should be treated, and patient should be started on beta blockers too. Now, the role of TIPS in management. Now, after the technical details, I want to get into how they are used for managing acute variceal hemorrhage. And I'll start with the role of TIPS in management of esophageal varices and gastroesophageal varices, type 1. Okay, shifting gears back to type 1. Now, firstly, I want to go over this, this type of TIPS jargon now, which you will come across everywhere, wherever there is conversation about TIPS and variceal hemorrhage. So first, we have preemptive TIPS, referred to as early TIPS also. Now, this is a TIPS that is placed preemptively within 72 hours of the hemorrhage in patients in whom hemorrhage has been controlled with medical and endoscopic therapy. And these patients are at high risk of treatment failure. So you've already done the banding. In the recent past, you would say that that's it. You come back again for banding. Here's your beta blocker. But now you will decide who are patients for high risk of treatment failure and preemptively consider a TIPS and put on them, and therefore the word preemptive. Now, salvage TIPS, all of us will be familiar with this. This is a patient with uncontrolled bleeding despite medical and endoscopic therapy, always in the middle of the night somehow, who needs a salvage TIPS. Now, rescue TIPS is the TIPS that is placed early within 5 days for recurrence of variceal hemorrhage. This is the patient where you thought that, okay, everything is good, and the patient gets moved out of ICU and then vomits blood again. TIPS for secondary prevention of variceal hemorrhage. TIPS placed on a patient who has recovered from acute variceal hemorrhage and is more than 72 hours after the index bleed. This also could be a patient whom you did not consider high risk of treatment failure. You treated the variceal hemorrhage, you send the patient back home. You even called the patient back in 2 weeks and banded them again, but they still presented with another variceal hemorrhage, and you should consider elective TIPS in this person after you control bleeding. Now, the role of TIPS in management of variceal, esophageal varices and gastroesophageal varices, to continue this, the determination of whether you put a TIPS is a balance between whether the patient will rebleed. The current standard therapy for variceal bleeding is, you resuscitate the patient, give them blood in a restrictive transfusion strategy, ideally. Then there is vasoactive agents, antibiotics, and early, within 12 hours, ideally, esophageal variceal ligation. In spite of all of that, 10 to 20% of these patients will rebleed within 5 days. Okay. Now, those patients that rebleed also tend to be very sick. They are child C patients. And if you consider TIPS in those patients, it can lead to acute and chronic liver failure with high mortality. So the determination of TIPS is to balance these risks, person who bleeds higher and the person who will decompensate with TIPS, and see whether that, who should be a patient. Now, it should not be performed for primary prevention of variceal bleeding. Okay, it's always after the patient has bled. And in patients with acute variceal hemorrhage, this preemptive or early TIPS should be considered in patients with child Pew class C 10 to 13 points, or child Pew B 8 to 9 points with active bleeding. There is some debate about the latter, but for now, this is what the studies have used. Most studies have used, and so child C, but not the 14 and 15s, who are very, very sick. And child B with 8 to 9 with active bleeding on initial endoscopy. You're seeing that spurting vessel. When you go in, you're seeing the stomach full of, there's also debate about the stomach full of blood, but yes, active bleeding. Now, role of TIPS as salvage and rescue treatment in long-term management of bleeding esophageal varices. Now, TIPS should be used as salvage in whom variceal bleeding cannot be controlled with medical and endoscopic therapy. That is the failure of standard of care. It should be used as a rescue in patients with early recurrent variceal bleeding, despite medical and endoscopic therapy. That is within 5 days. Now, there is a futility argument here. In patients with MELD more than 30, lactate more than 12, or child Pew greater than 13, a salvage or rescue TIP should not be used unless TIPS is a bridge to liver transplantation in the short term. Now, in patients who have recovered from variceal hemorrhage and who did not have TIPS placed in the first admission, TIPS should be considered a second-line therapy when rebleeding occurs, despite of secondary prophylaxis, non-selective beta blockers, and endoscopic therapy. Now, going on to gastrofundal varices. So we've been talking about esophageal varices in GOV1, that is labeled here, but these are GOV2s. Sometimes they can be IGV or isolated gastric varices 1, and there are multiple considerations when you decide how to treat them. We have to consider the location of the varices, the anatomy of the supplying and the draining vessels, the presence of shunts, and the flow dynamics in the circuit, presence of splenic vein thrombosis, and the liver function of the patient. And the indication of this preemptive TIPS and salvage and rescue TIPS for these varices are similar to that what we discussed. But we're going to discuss, after considering all these considerations that I put in there, when is TIPS used? So first of all, TIPS or RTO, is not the first line treatment to prevent hemorrhage in patients with gastrofundal varices. Now, there is some debate here. I believe there is only one study which has done a randomized control trial in 2002. I think that came out of Delhi, with the first author being Dr. Mishra, I think. And it randomized people in 30 people in 3 different groups. So 30, 30, 30, in people who got preemptive RTO. And did they get RTO? Yes. No, they didn't get RTO. They actually got cyanoacrylate injection into gastric varices. So it wasn't even RTO. And the second group got beta blockers, and the third group did not get anything. And it showed that the bleeding in patients who got cyanoacrylate injection as primary prevention of gastric varices was lesser. Now, again, these varices in this study were large. They were like more than 2 centimeters. then most patients had alcohol-related cirrhosis, and this study has really never been done again. And so there is very little evidence to treat gastric varices either with RTO or cyanoacrylate injection as primary prevention. So and many studies, especially studies that come out of Japan, who are leaders in the development of these technologies, they mix these patients. They mix the never bled and bled patient, which is just like wrong on multiple fronts. But I didn't write those studies, so but I was given the task to interpret them. The bottom line is that there is no robust evidence for TIPS or RTO or for that matter endoscopic therapy to prevent first hemorrhage in patients with gastrofungal varices. In patients with acute hemorrhage from gastrofungal varices, either cyanoacrylate injection, TIPS, or RTO can be considered as first-line therapy to control bleeding and prevent rebleeding. Now, RTO is the first-line endovascular option for hemorrhage from gastrofungal varices in patients with contraindications to TIPS. In patients with hemorrhage who are candidates for both RTO and TIPS with gastrofungal varices. Now, you do RTO in patients who has like a history of overt encephalopathy, the liver function is not very good, and TIPS when there are other complications such as esophageal varices, significant ascites, portal vein thrombosis, TIPS is favored. Now, on a case-by-case basis, as we discussed, you still can have a lot of flow in those varices in spite of the TIPS, and TIPS can be complemented with variceal embolization as this may reduce the risk of hepatic encephalopathy and rebleeding. Now, a brief touch point on ectopic varices. These diagrams show duodenal varix and rectal varix, and you can also have stomal varices at the site, such as at an ileostomy site. Now, ectopic varices are a rare complication of portal hypertension, and bleeding in all gastrointestinal bleeding, in all portal hypertensive gastrointestinal bleeding, bleeding from ectopic varices is relatively rare. But when it happens, it's quite dramatic and it can be difficult to control. And the management should be determined by a multidisciplinary team with hepatologists, gastroenterologists, IR specialists, and surgeons. And we do not have a one-size-fits-all approach, and they all should get comprehensive imaging to define this anatomy, which would be required for this individualized treatment approach. Now, endoscopic therapy for these ectopic varices may be used as a bridge for more definitive interventional radiology therapies. And data on this is mostly case series, and it depends upon the availability of expertise. And like at our center, it's just not available. Now, TIPS is the first-time treatment for most ectopic varices, and for ectopic varices specifically, almost always they either need a ATO or RTO along with the TIPS. And in patients who are poor candidates for TIPS, in whom collateral feeding vessels are small, ATO and RTO alone may provide sufficient control of bleeding. So there are some recurring concepts I hope I've been able to put forth. It's that the imaging is important. It is important to look at the flow of the varices, and TIPS may not fix everything, and you might need RTO or ATO. In some patients, TIPS may not be feasible. All you can do is ATO or RTO. Now, to summarize everything, we can go over an algorithm for acute variceal hemorrhage. And let's say that we have a patient with acute variceal hemorrhage. There'll be hemodynamic risk, suspected acute variceal hemorrhage. You'll resuscitate the patient, cautious PRBC transfusion with a restrictive transfusion strategy, short-term antibiotic prophylaxis. Looks like I missed that vasoactive agent. I'm not entirely sure why. Followed by endoscopy. Now, let's say you find those esophageal varices, you will do variceal ligation. And if you do not find esophageal varices and you found gastric varices, we'll talk about that in the next algorithm. Now, after variceal ligation, if you control bleeding, if you did not control bleeding, we'll go for that salvage TIPS. If there is high risk of bleeding, if you control the bleeding and there's high risk of bleeding, you'll go for that preemptive TIPS. And if the patient is not at high risk for bleeding, you will continue these vasoactive drugs for 2 to 5 days. If there's early bleeding, we'll go for the rescue TIPS. And if there's no early bleeding, thankfully, we'll initiate beta blockers when stable and discharge the patient, hopefully. Now, this is the algorithm for gastrofundal varices. Now, you found those gastrofundal varices in endoscopy. Do you have endoscopic therapy available? If yes, you can do cyanoacrylate injections or EUS-guided therapy, which are varied. It can be coils and glue, it can be thrombin injections, it can be sclerosant, it can be cyanoacrylate. And then if there's rebleeding, you do the cross-sectional imaging. And if there's no endoscopic therapy, you do the cross-sectional imaging. But if your endoscopic therapy was successful, you again look for flow in the complex, repeat the same treatment that you did or a combination thereof, and go forward. But let's say there's no endoscopic therapy, you've done that cross-sectional imaging, and you see that both TIPS and RTO are feasible. Then you think about TIPS when there's good liver function, large esophageal varices, and portal vein thrombosis. Whereas RTO, if there's previous hepatic encephalopathy, poor liver function, and local expertise is available, you must see that this algorithm is a generalization of my last 40 minutes of talking. Okay, so there are other factors to consider, but in general, okay. Now, let's say both TIPS and RTO are not feasible, but TIPS is feasible. TIPS is not feasible. Only RTO is feasible. You'll do an RTO. And if TIPS is feasible, you will perform TIPS. And if there's persistent fugal variceal filling after TIPS, or if you have a high risk of encephalopathy, you will go on to embolize those varices. And that is the best I could summarize this complex management of gastrofundal varices. And I hope that was helpful. That's all I have today, and I'm happy to take any questions.